biopsy, a renal biopsy should have been would have been done. But then yeah, she has a lot of family issues which may have prevented her from getting the right kind of health care that she needed.
Also, is there family history? Could she even have multicystic, does everyone in her family have an elevated creatinine or?
Right, like autosomal dominant polycystic kidney disease is, I guess.
Yeah, I'm just looking up something,
Yeah.
but you know what I'm saying is just, even by history.
Yeah, but I think we have an ultrasound of a kidney which hasn't revealed any polycystic kidney disease. So it is more of a corticomedullary differentiation problem, which has been classified as a renal parenchymal disease. Some grade has been given to it. So all we have is a very non-specific renal disease for now. And what about proteinuria? What about glomerular involvement? Any active sediment like RBC in the urine? Any proteinuria that we could know? And her serum albumin was also normal. So very, very peculiar, a kind of a chronic renal failure which doesn't seem to be having too much of a glomerular, active glomerulitis. And it's most likely looking like a tubular interstitial nephritis, which is chronic. And in India, particularly in the developed world, we find this commonly happening because of inappropriate usage of antibiotics, which can cause drug-induced tubular interstitial nephritis. So, I mean, that could be one of the possibilities here.
Okay.
So let's go ahead. Yeah.
In December, she had worsened shortness of blood and abdominal distension. While investigating, USG showed hypoechoic lesions in the liver, so FDG PET was advised. And it showed metabolically active lesions and lung consolidation, mild pleural effusion, and thickened peritoneum. So the report was given to rule out Cox disease. So they have started her on anti-tubercular therapy based on clinical radiological diagnosis, and they discontinued her immunosuppressing therapy.
What immunosuppressant therapy was she on?
Mycophenolate and mycophenolate.
Oh, okay. Okay, that's right, okay.
And when was this started? November 2022.
No, sorry, December.
December.
In September.
September she was started on the immunosuppressants.
After her autoimmune panel, they did not diagnose what it is, but
Yeah.
they started her.
Okay. So she had an autoimmune panel positivity and they just started on immunosuppressants in view of what did they want to suppress? What kind of a immune activity was active at that time? Because of which they went to the, she went to the doctor at that time, September 2022.
Actually, she developed like hyperpigmented patches over the
Cutaneous activity. So certain hyperpigmented patches may not be a vascular, may not be inflammatory. Well, was it inflammatory?
non-inflammatory.
Okay. What other inflammatory activity could be perceived at that time when they started her on immunosuppressants? Basically to have an anti-inflammatory effect.
Okay, there are blips over the upper limbs. Like
So she had a cutaneous lesions with blebs, which could be inflammatory. I can see that we have a dermatologist Dikshita here, and she may be able to comment on that. And what else? Yeah, I think she came to us also with those blebs, those cutaneous active lesions. Yeah, okay. So basically, they wanted to suppress that cutaneous inflammation and nothing else. There was nothing else on the surface. Okay.
So they're giving her all this medicine for her skin.
Yeah, that's very
But
strange.
she's in renal failure.
Yeah, and she has got chronic renal failure too. So that's very strange, and maybe Dr. Dikshita can also comment on that part. I'm sure you must have discussed it with her, this patient before, and they've also seen it. And I think they've taken a biopsy of her skin.
previously it was done outside, sir.
Outside, yeah. But you must have discussed it with her. Okay. Yeah, let's continue.
She also had joint pains, ma'am, along with skin lesions. We don't know what with description of the skin lesions. Her academics weren't able to describe those. But she even had severe joint pains at the time, and she had joint swellings. That's what we got to know through the attendant. We couldn't, she was.
So what joints? What joints were hurting her?
Which joints were hurting her, and yeah, was it specifically mentioned? Because this was a patient reported history,
Yes.
so we really don't have the data on the particular joints. But if some doctor has started on mycophenolate and other immunosuppressants, I'm sure he would have made a note of the joints involved. Because if you've seen the ANA profile, I'm sure there would have been a clinical profile of the joints that were involved. Do we have those papers? Or it is only the tests, the ANA profile that has survived in her records, but the clinical profile has vanished.
Some papers were missing, some documents were missing.
So you see, Michelle, this is a very, very common problem in rheumatology and of course in medicine in general, that we really don't have the proper sequence of events because the records are missing often.
Yes. I'm much more aware of this than I was even when I was down there before.
Yeah.
Yeah, it's very sad because you really don't know what's going on.
Yeah.
And they use these powerful medicines.
Yeah, most of our interesting cases are not getting reported because of this problem. That it's not being documented at each and every point of entry into the system. When the patient sees multiple physicians, and then she uses everything, and the onus is on the patient to maintain the records, not on the physicians. So I think here is a very important part about training that needs to change, where the onus should be on the physician to maintain the records.
No, the electronic medical records are a real hassle, but this is what they do. And yes.
Yeah, I mean, they are a real hassle for physicians, especially in US. But yeah, if we can really, if the workflow is good, then at least we have all the sequence of events in proper place and we can figure it out better. Okay, so we'll move to the patient. Yeah.
Yeah, and I'm fading, so we're going to have to move very quickly. Because
Okay. Right. So we'll go to the catastrophic part. When she came. This time to us for the first time, yeah. Haripriya is going to take over. Yeah. Quickly before Michelle fades. Yeah, Haripriya, where's your PowerPoint? Can you identify that? Haripriya's PowerPoint.